Following on from the lecture on understanding pain and the lecture on inflammation and wound healing, we're now going to look at analgesics and anti-inflammatories. This slide was at the end of the Understanding Pain lecture and introduced us to analgesia. We can see on the right a stepped model for which types of drugs would be used in which level of pain. So mild pain tends to be the non-opioid drugs, so we look at paracetamol and the non-steroidal anti-inflammatory drugs. Once we're looking at moderate pain, we're looking at a mix of opioids and non-opioids. And then once we're into the severe pain, then we're looking at the opioid group and the synthetic opioids as well. Certainly the non-opioids are also used at that level. The other way we can treat pain is to use analgesia that is the result of anesthetics. So you'll notice on the left-hand side there we have a graphic that's looking at local anesthetics blocking pain signals to the spinothalamic tract, or using things like epidurals and local anesthetics to prevent pain signals from further up the pain pathways. Earlier we looked at the types of pain and we looked at nociceptive pain and we separated into somatic or visceral pain. We do use different drug groups for each type. So somatic pain is more often than not the non-steroidal anti-inflammatory drugs, whereas the pain that's coming from large muscle masses and organs tends to be treated with opioids. With the neuropathic pain, where it's an actual nerve lesion or nerve injury, we tend to use the opioids, but more recently we've been using, or at least the people who prescribe drugs have been prescribing the GABA-mediated drugs. And what those drugs do is actually, because GABA is an inhibiting neurotransmitter for the pain pathway, then there are drugs that can enhance GABA's effect, such as pregabalin. Capsaicin's an interesting one, and we'll look briefly at that, and then we'll look at the local anesthetics and have a very brief look at the general anesthetics. With neuropathic pain, we need to think about adjuvant therapy, and that means looking at things like using anxiolytics and antidepressants as a means of helping patients deal with chronic pain. There is also the breakthrough pain, and the breakthrough pain is where we're seeing people who are wanting their analgesics earlier than the timeline for redosing allows for, which often happens in those with chronic pain. And so this is where they might use other types of drugs or introduce some short-acting opioids to tide people over that gap in analgesia. We've also seen this table before in an earlier slide set that compares acute and chronic pain, but previously we just looked at down to the level of pain, and now we can add in the therapeutic goals and the drugs that are used to meet them. With the acute pain, it's often about the opioids, because if it's traumatic pain that's causing the problem, then sedation's not a problem. So in fact, sedation can be very helpful, and consequently using the opioids in those circumstances are quite worthwhile. So the post-surgeries or the major trauma type effects. Whereas the chronic pain, sedation can be detrimental to daily living aspects, and so we tend to see the paracetamols, the non-steroidal anti-inflammatories, and the adjuvants used And the opioids are used because of the problems of taking them long term more carefully and more conservatively. Okay, we're going to start with the non-steroidal anti-inflammatory drugs. So that's what NSAID stands for. And aspirin is the prototype drug for this particular grouping. So by prototype it means that it was the first one recognized in the group and that other drugs are compared, the actions of other drugs are compared back to it. It's also known as being a salicylate. So you'll find sometimes that they'll talk in the books about the salicylates, and they mean these non-steroidal anti-inflammatory drugs that fit within that chemical category. Aspirin acts as an antipyretic, an antiplatelet, an anti-inflammatory, and an analgesic. We're going to talk about antiplatelet properties for things when we do the cardiovascular topic, and we've talked a little bit about it along the way anyway. Today we're going to talk about the antipyretic, anti-inflammatory and analgesic effects because they all relate to the production of prostaglandins. And prostaglandins sensitize the nociceptors so that we send the signal through to the brain to say we're in pain more easily. They trigger the hypothalamus to cause a temperature to be raised so that we increase the body's set point, and so that's act as a pyrogen. And as a prostaglandin acts to stimulate the inflammatory effect, so part of the vascular permeability effects and some of the chemotaxis effects are related to prostaglandin function. So if we give aspirin, we inhibit prostaglandins and therefore we inhibit all of those effects. Now, the way the NSAIDs work is that they're non-selective. So we have enzymes called cyclooxygenase, and we have more than one of them, and cyclooxygenase 1 and cyclooxygenase 2. So the NSAID group of drugs are indiscriminate about which enzyme they inhibit. And we know that the inhibition of COX-2 is associated with reducing inflammation. And we know that the inhibition of COX-1 is associated with most of the side effects of these drugs, and consequently there was a development to try and create a inhibitor of COX-2 that only inhibited COX-2, and that brought about the group of drugs called the COXIBs. Looking at this graphic, we can see the COX-1 and COX-2 pathways separated out. Now, COX-1 pathway, it looks at it as physiological stimulus, so these are the protective mechanisms related to COX-1 pathway, and it is phospholipase that releases arachidonic acid from the cell membranes. And if COX-1 acts on arachidonic acid, then we have the production of thromboxane, which is about platelet aggregation, prostacyclins, PGI2, which has to do with vasodilation, decreasing platelet aggregation and decreasing gastric acid secretion, and PGE2, which is prostaglandin E2, and that's acting to vasodilate in the kidneys. So those things are affecting the stomach lining and the amount of gastric acid in them, the blood flow through the kidneys for glomerular filtration rate, and increasing platelet aggregation, and has an effect on vasoconstriction. If we have a look at the COX-2 pathway, this is the pathway that has to do with our inflammatory responses, and in this case phospholipase releasing arachidonic acid. If COX-2 is the enzyme acting on arachidonic acid, then we end up with the pro-inflammatory prostaglandins along with prostacyclin PGI2, which decreases platelet aggregation and has an effect on vasodilation, and PGE2, which again is going to have a role in vasodilation in the kidneys. When we inhibit them, and if we inhibit COX-1 and COX-2 indiscriminately, then we can see that we impact on platelet aggregation, which can result in bleeding, We can impact on the gastric acid secretion by not lowering it, so we lose that protective effect and we end up with gastrointestinal ulcers. We alter the blood flow through the kidneys, and by decreasing it we can start to have an impact on the nephron's filtration mechanism, and we also can have an impact on blood pressure because we increase sodium retention and therefore increase water retention and therefore increase blood volume. Certainly by inhibiting COX-2 we're decreasing inflammation, we're decreasing fever and we're decreasing pain, as we've discussed. But we also get an increase in the production of thromboxane. So these things are all issues in that if we indiscriminately inhibit COX-1 and COX-2, yes, we decrease the inflammatory responses and provide analgesia and decrease fever, but all these other things are going on as well. So it's not a drug that you want to be taking all the time. So these are the different groupings, chemical groupings for the NSAIDs, and you can see aspirin sitting under the salicylates label up the end, ibuprofen sitting under the propionic acids, along with naproxen, and you can see that indomethacin and diclofenic acid are sitting up with the acetic acids, and the COXIBs are right down the right far end of this table. Now the COXIBs only inhibit COX-2, and that means that we get the anti-inflammatory effect as we saw on the previous slide. We do get some change in thromboxane levels though, and when they introduced the COXIB groups, celecoxib, etarocoxib, paracoxib, they realized that after having it out on the market for quite some time, that cardiac events were occurring, and that's been traced back to what they believe is the unopposed action of thromboxane leading to thrombus occurring, so platelet aggregation. Consequently, you can't, unlike ibuprofen where you can actually buy it in the supermarket, you can't buy celecoxib in the supermarket. You need to have a script for it because they're very careful about giving it to people with cardiac disease or who have the risk factors for cardiac disease. I've also put a note here about paracetamol. Paracetamol, there's always this discussion around whether paracetamol actually belongs with the NSAIDs or not, and that's because it has no anti-inflammatory or effect. It also has no antiplatelet effect. It does, however, act on COX enzymes. Exactly how it achieves what it does is problematic. They know that it acts in the central nervous system, and in that way it seems to act as an antipyretic and act as an analgesic. Now, the opioids are analgesic drugs. The prototype drug for the opioids is morphine, which is derived from the poppies. And we call them opioids because they are drugs that will act at opioid receptors. So the main receptors are mu, kappa and delta, and it is in fact the distribution of those and the effects they have that account for the side effects and the analgesia that we see with opioid use. These drugs inhibit the excitatory transmitters, so they inhibit things like the tachykinin substance P. They do so at the spinal cord, and they also do so at the supraspinal level in the central nervous system, and that means the limbic system around the thalamus and the midbrain. Now, because they're acting in the limbic system, they alter your perception of pain and they alter the emotional response to pain, so they tend to lessen the anxiety response to pain. It also means that if you talk to somebody who's taking opioids as an analgesic, they say, yes, I still know I'm in pain, but it feels like it's at a distance or it's not worrying me as such. So it has that impact on the limbic system and how we behaviorally respond to pain. Now, All the receptors are associated with the side effect of constipation. They act on smooth muscle contraction, slowing it down so that the bowel slows down its process of pushing things through. All the receptors have a role in analgesia. The mu receptor also has a role in euphoria, which has the connection to people misusing the drug. There is also the aspect of dysphoria associated with the kappa receptor, which is the person who turns around and tells you that morphine actually makes them feel quite bad. And then there's the delta receptor, which has a role in constipation and analgesia as well. Now, you will see that we're talking about opioids. If they are referring to an opiate, so an O-P-I-A-T-E, they're talking about the drugs that are created from the plant itself, whereas the opioids title includes everything, including the synthetics. Now, as I said, morphine is the prototype drug, so it's the one that all the other drugs in this group are compared back to, and morphine predominantly acts at the mu and kappa receptors. There is a partial agonist drug, which is buprenorphine, and it's only acting at the mu receptor. And where the antagonist drugs, naloxone and naltrexone, are drugs that reverse the effect of drugs like morphine. But you'll notice with the partial agonist, naloxone only partially reverses the drug. It doesn't fully reverse it. The thing to realize about these drugs that are used for reversing overdoses of the opioid drugs is that their half-life is shorter than the original drug that was taken, and that means that these patients need to be monitored because it depends how much drug they took. But if the half-life of the antagonist drug means that it's being excreted faster, then you may well see somebody start to slip back into overdose circumstances. What they have learnt is that by combining the agonist and antagonist drugs, and you will find on the market that there is a drug that combines oxycodone with naloxone, this combined drug means that some of the side effects are mediated by the antagonist drug. So they include in the combination drug slow release naloxone, and that limits the effect on smooth muscle relaxation without affecting the analgesic effect. And so that combination of drugs is being seen more and more often used with patients who need to take the opioid drugs on a regular basis. This table from your textbook puts all this into one spot for you. I've put red boxes around the antagonist drugs to make them more visible in the table. You can see there that if the drug is acting on the mu receptor, then it is acting above the spinal cord. It's creating euphoria, which was mentioned earlier. It also has a role in respiratory depression and a level of sedation, along with things like constipation, meiosis, and drug dependence. If we look at the antagonists for any of the mu receptor drugs, then we're looking at naloxone, naltrexone, and nalifrine. And they reverse the effects, induces quite sudden withdrawal from the drug. The kappa receptors, there's again are reversed by naloxone and naltrexone, and kappa receptors are both spinal and allow for peripheral analgesia. They also have a role in sedation, As mentioned earlier, they have a role in dysphoria and they have a role in respiratory depression. Meiosis here, M-I-O-S-I-S, has to do with pupil size, and the pupil size changes with these receptors being triggered. With the delta, we can see there that the enkephalins and beta endorphins are actual agonists for the delta, as we also notice beta endorphin for the kappa and beta endorphin for the mu receptors. So these are our endogenous opioids that work on these receptors, and again, they can have an effect with respiratory depression. They can have that spinal analgesia effect, and they have a few other roles there, such as in neuroprotection and cardioprotection. But again, they can be reversed with naltrexone. I mentioned codeine when we were looking at genes and their influence on enzymes, and what enzymes a person has. And revisiting it here, we can see that there is a particular genotype associated with the usual processing for codeine into morphine by the liver. Then there are 5 to 10% of people who have the genotype for the enzyme, the cytochrome enzyme, that makes them poor metabolizers, and so they don't convert the codeine to morphine, or at least not at the same level that most people do. And that means the analgesic effect doesn't exist. There are a rare few people who are ultra metabolizers. They have the genotype to actually process the drug more rapidly, and this group are at more risk of drug toxicity than others. So those enzymes in the liver have a role to play with any of the combination drugs that include codeine in them. And certainly if a patient turns around to you and says that it's not having the effect they expect, then they may well be one of these 5 to 10% who don't actually convert the codeine. Neuropathic pain has the reputation of being difficult to treat, where the nerves are damaged or injured and are generating pain. So GABA stands for gamma aminobutyric acid, and we came across it in the Understanding Pain Pathways lecture as an inhibitor of the pain pathway. So it inhibits the action potential transmission, and it does that through inhibiting calcium release. So there have been drugs that have been developed to do this. Pregabalin is a mimic, an analog of GABA, and as such it enhances this GABA inhibition of the pain signal, and it's a drug that's been used increasingly more often in the last few years for neuropathic pain. Another drug that works similarly on GABA is gabapentin, and it's been traditionally used as an anticonvulsant. The thing about these drugs is that they do have a number of adverse effects, and they can affect coordination levels, they can cause some level of sedation. They're known for causing some ocular dysfunction, so eyesight problems, related to weight gain and to dizziness. Now this is just a brief word on the chemical capsaicin. Capsaicin's interesting because it works from a very different principle than the other drugs do. If we activate capsaicin receptors, we cause the nerve to release substance P. So it's a chemical that's derived from chili peppers, and the mechanism of action of this particular drug is to essentially exhaust the substance P reserves, so the tachykinin reserves, so that you can't keep sending the signal. So a very different mechanism there, in that if you give the drug, you're actually going to cause the nerve to release substance P, and the analgesic effect will be the result of exhausting that storage of substance P so that the signal can no longer be sent. We know that in chronic pain, a number of adjuvant therapies are very helpful. One that's fairly obvious is the biphosphonates for patients with bone metastases and therefore bone pain. In that biphosphonates are chemicals that help stabilize bone by becoming incorporated into the bone matrix. And so the use of biphosphonates in bone pain and cancer is an adjuvant therapy to help with pain stimulus. The corticosteroids are used because they inhibit the release of or the actions of phospholipase, and therefore we don't get arachidonic acid being produced, and therefore we have nothing for the COX enzymes to work on. So they reduce inflammation overall. And then there are the NMDA receptor channel modulators, and NMDA stands for N-methyl-D aspartate. It's a glutamate receptor, an ion channel, and we know that hypofunction of this particular receptor has an impact on things like memory and learning impairments. This receptor is found on nerve cells, and it's activated by glutamate and glycine, and again is related to the calcium permeability of the neuron. What they've realized in the last couple of years is that using sub-anesthetic levels of ketamine, ketamine is an anesthetic, but by using sub-anesthetic levels of ketamine, these NMD channel receptor modulators can in fact have a role in controlling neuropathic pain. The other drugs on this list are the tricyclic antidepressants and the psychoactive drugs that are anxiolytics. So by anxiolytics we mean the ones that will lessen anxiety. The thing about these anxiolytics is they do have some sedating properties around them, but by lessening the anxiety you can lessen the pain response. And we also know that the tricyclic antidepressants have a role in this behavioural response to pain, and certainly because chronic pain can lead towards depression, so often the comorbidity with chronic pain is depression. So that brings us to the anaesthetics. Local anaesthetics, the idea is that the drug itself doesn't leave the area that it's applied to or injected into. They work on inhibiting the sodium channels so that there is a limitation to the capacity for the action potential to be carried. And they're used obviously in surgical use. They can be used for pain relief. Ideally, they only act on the sensory nerves, so they shouldn't be acting on the autonomic nervous system and the motor nerves. And by the autonomic nervous system, we're talking about respiratory rates and cardiac heart rates and those sort of autonomic functions. It is, however, dependent on the lipid solubility of the drug as to how well it stays in place. It's also dependent on the nerves that it's acting on, so levels of myelination, the diameter of the fibres, the length of the fibres that are exposed to the local anaesthetic. We can use some of these parenterally. Some of them can be used topically. You can buy lignocaine as a pain reliever in the commercial drug Soothe that you just wipe on the skin. It's a gel you wipe on the skin that works that way. There are a couple of other topical drugs that can be used to minimize surface sites for when kids are having things like drip lines put in. So these drugs are really, the best of them stay contained in the area they're applied. So this little flowchart is giving you a sense of what goes on with the local anaesthetics. The idea is they're put into the tissue at the site where they need to be given, and that may well include things like epidurals and doing nerve blocks, or localized within tissues to put sutures in, that sort of thing. So the onset of action of the drug is important. But if they are absorbed into the bloodstream, which to some extent they will be, they are then distributed to the other organs and tissues, and in particular to the liver and kidneys. And the liver will metabolize them. The kidneys will then excrete them. If they do get to the organs and tissues, then that's where the adverse effects can come in from these drugs, because if they start to have an effect on the brain and create some drowsiness or have an impact on the cardiac heart rate and cardiac output. And that brings us to our last slide in this slide set, which is a brief introduction to the general anaesthetics. There's three main targets for the general anaesthetics. We've already talked about GABA receptors, and we've talked about NMDA receptors with our previous note on ketamine. And the other site for these drugs are the potassium channels, again with that view to altering the capacity for sending an action potential through the nerve. The potency of the general anaesthetics is strongly associated with their lipid solubility. They need to be lipid soluble in order to move across into the brain, across the blood-brain barrier. The characteristics of them are based around their onset times, whether they can be extended during surgery, and how easily reversed they are. And of course, the best of them will be easily reversed and rapidly reversed. What they do is depress all the excitable tissues, so they decrease the capacity to have a response to the excitatory neurotransmitters. We talk about stages of anesthesia. So initially it's about analgesia. There is a stage which is variable amongst people as to a level of reflex excitement. And then we get to the surgical anesthesia stage. If it goes too far and we end up with medullary paralysis, that's our toxic stage for any of these drugs, and this is where you start to see things like respiratory arrest and vasomotor collapse. So vasomotor having to do with our vessels and our capacity to actually pump blood.